Today we had a Pandora's box, which is thyroid. Okay. So, any exam candidate other than Sumera? Anyone for oral exam other than Sumera? Azhar for written, Aiza. Okay. Anyways, so like you people know that I'm just, my aim always is to give you people a concept, okay, because everything is written in the books, and nobody at this level is going to teach you in a way that they are giving you a notes, they are giving you something to swallow and even to make you digested, and just like a baby, they are making to digest the food, the milk. Okay, that's a wrong approach. You people just need a guidance that what may be the possible questions and what could be the answers and what are the highlighted or pearls of a topic. So actually thyroid is a big topic. We will just try to, first of all, my aim will be to give you a concept that what things you should be knowing about thyroid. Okay, specifically because back in Pakistan, our this is one of the most commonly asked long case. Okay, so my aim will be to attend that people, and in no exam, MCQs, written based exam, there no exam is completed without thyroid. Not only because of thyroid as an endocrine organ, but because of the presence of thyroid in the area which is the you can say the business end of anesthetist, the airway. Okay, so this is something to start with. And if you are thinking about thyroid, so actually there will be the cases which you will be dealing will be a thyroid patient for thyroid surgery, or a thyroid patient with non-thyroid surgery. Okay, so like majority of the things will be common, but some of the things will be different. Okay, so whenever you are thinking about thyroid, you should be knowing about the anatomical location. So Sumera, do you remember the levels at which the thyroid gland is there?
Sir, it's located at the level of C5 to T1.
Okay, C5 to T1. Okay, is your answer a good one? Because what is between C5 to T1? Is it lobes, or is it isthmus, or is it whole gland?
Sir, it's a whole gland C5 to T1.
Okay, so because MCQs will be on based of this fact. Okay, this is the whole extent of the thyroid gland. And what about the ring, tracheal ring? Will it be above the tracheal rings or below the tracheal ring? At what level they will be? Yes. Yes, Aiza?
Sir, it's on second, third, and fourth tracheal ring.
Okay. Okay, so this is the basic anatomy you should be knowing. I will just give you a taste. Then you should be knowing about the nerve supply, the arterial supply, okay, and the venous drainage. So you should be knowing about it. We don't have the time to discuss each and everything. So I'm just, you should be knowing just the main. If you want to block, if you want to give some like a nerve supply of the area for thyroid surgery, which block you can give?
Superficial cervical.
Superficial cervical block.
Like your answer should be cervical plexus block. Okay, whether you are uploading it with superficial or intermediate or deep, that is something else. Okay, that is the way of techniques, but cervical plexus nerves will be there. So this will be one thing. And arterial supply is superior thyroid artery and inferior thyroid artery. If I'm not wrong, I don't remember exactly I think they are branches of external carotid. Am I right?
Sir,
Sir,
superior
superior
thyroid
thyroid.
artery is a branch of external carotid artery, and inferior thyroid artery is a branch of thyrocervical trunk.
Thyrocervical trunk. Okay. Yeah. Yes, Aiza, anything else you were saying?
No, no, sir, that's what I want to say.
Okay. So it is better if you people raise hand and then I will ask the question so that there is no doubling or clash. Okay. So this is something basic, and then comes this is the anatomy, and this is the come the physiology. Okay, so the physiology and pharmacology actually are related. So if you are going even for long case or even in the MCQs, the question will be that how thyroid hormone is synthesized. Okay, so can Aiza, yes, tell please.
Sir, iodine leads to iodide.
I'm sorry, it's by mistake. Unmute yourself, please.
Okay, so sorry. Sir, iodine leads to iodide in the GI tract, rapidly absorbed in blood, and then transport to the thyroid follicular cells. Oxidation of iodine to iodide in the presence of peroxidase, and then the step that is organification, binding to iodine to thyroglobulin, and it is catalyzed by enzyme iodinase enzyme and yield monoiodotyrosine and diiodotyrosine, and then the coupling occur to 25% monoiodotyrosine and the rest diiodotyrosine via thyroid peroxidases, and then it forms the T3 and T4, and then endocytosis more T4 to T3. T3 and T4 remains attached to thyroglobulin and are stored as colloid until they are released into the circulation. More
Okay.
T4 than T3.
Okay, so you first of all is the dietary trapping, iodide trapping. Okay, then it's the oxidation, as you told. Iodide is oxidized to iodine, and then iodination with the tyrosine. So monoiodo, tyrosine, and diiodotyrosine. Okay, if two diiodotyrosine combine, they become T4, and one mono and one di combine, it become T3. Okay, so the T4 is stored in colloid bound to thyroglobulin molecule. So this proteases digest iodinated thioglobin, releasing the T4, T3, biologically active agents central to metabolic regulation. So another question will be that what is the half-life of T4 is about 5 to 7 days, and a half-life of T3 is only 24 hours. But T3 is the active one. Okay, so the one which is special will remain for shorter time. Okay, T3 is 4 times more active than the more abundant T4. So this is even this question will be asked in the MCQ as well. Okay, and so another will be that for example, in liver disease, because it is bound to globulin, a small fraction is free. Albumin, I think main it is attached to globulin. So that's why liver failure does not, if just correct me, that liver failure does not increase free hormone. Just correct me if I'm wrong. Will it affect? Anyone, please? Because I cannot recall this fact. Aiza or Sumera, if anyone wants to correct it.
Sir, in case of liver failure, there will be decreased level of globulin and albumin like proteins. So there will be, I guess, free
Increase.
fraction of hormone will be more.
Okay, because actually, if I'm not wrong, the ratio is changed in liver failure. Albumin globulin ratio is changed. So I think more effect on albumin than globulin. If I'm maybe because this fact I cannot recall. So just make sure you people confirm it, and even you can share in the group. Okay, just to speed up our discussion. Okay, and the regulation is by TSH, and TSH is released by pituitary, and the grandfather is hypothalamus. So it is from this THRH, thyrotropin releasing hormone. So This is there is a negative feedback loop which is controlling this thing. So this point, please reconfirm it. Okay, about is this albumin globulin? Just reconfirm it, that what is the exact effect in liver failure. What more in globulin or albumin thing, something like that. I had read it, but I cannot recall it at the moment.
Okay, sir.
Okay, so this is one step, because whenever they are starting a question. So one thing, what is the mechanism of action of thyroid hormone? Yes, please. Who will answer? Azhar, you want to answer? Sumera?
Sir, their thyroid hormone after going into the blood, there will be that T3 is active, then it has a effect on different system of our body. It has effect on CNS, CVS, and respiratory systems. In CNS, it causes the myelination of nervous system, and on CVS, it increases the heart rate, cardiac contractility, and ultimately cardiac output. And
Actually, it is
respiratory
controlling
system, it causes.
It is controlling the basal metabolic rate. Am I right? So that's why whenever thyroid hormone is decreased, the metabolism becomes whenever thyroid hormone is decreased, the metabolism becomes slow, and whenever thyroid hormone is increased, metabolism increases. Okay, if you don't sometime in the exam, if they are asking you a question, if you don't know the exact answer, you can answer in a conceptual way, and they will not fail you if you tell them the correct way. Okay, so there are some receptors on which thyroid hormone will be acting, and whenever metabolism comes, the what is the part of cell which should be active? Mitochondria. Okay, because all the metabolism is controlled through mitochondria. Okay, so this is another point. And then, as you are saying, effect of thyroid hormone increase or decrease on different organ system. So of course, when you know the basic theory, you will be able to comment on the rest of the things. Okay, so now if I ask you, what are common causes of hyperthyroidism? Yes,
Sir,
Aiza.
Sir, it's grave disease, thyroid secreting adenoma, toxic multinodular goiter, or post irradiation thyroiditis हो सकता है, or exogenous iodine, amiodarone. These all causes hyperthyroidism.
Hyperthyroidism. What about
Yes, sir.
all the thyroiditis cause hyperthyroidism, except which is the thyroiditis which does not cause hyperthyroidism?
Hashimoto thyroiditis.
Hashimoto.
Okay, so Hashimoto's thyroiditis does not cause. So okay, so what are the common causes of hypothyroidism? Yes, Sumera. Causes of hypothyroidism?
Sir, there will be iatrogenic damage to the thyroid gland, and there can be during the like removal during surgery.
Okay.
And
Actually,
there will be primary.
The main what thing is making the thyroid hormones? So the biggest cause will be iodine deficiency. Okay, try to remain simple. Okay, and this one in the hyperthyroidism, one thing I forgot to mention, or you forgot to mention, is if, for example, patient is taking thyroxine, if there is overdose, it may also present as hyperthyroidism. Okay, so unless there will be some specific cause, you have to be, and in amiodarone there may be both hyperthyroidism, even in amiodarone, but it can cause hypothyroidism as well. Okay, so it causes thyroid dysfunction in both the ways. It may be difficult, it may cause hypothyroidism. Okay, so this is one thing. Then of course it will, whatever, whether it is hyperthyroidism or hypothyroidism, what is the common thing? Yes, please. It's a very simple answer. What is the common thing in just give me a second, please. I just have to attend a call, please. I'm sorry. Yeah, yes, my question is that what is the common thing in both hyperthyroidism and hypothyroidism? Yes, please.
Sir, in both there are systemic manifestations.
No, it's a very simple answer. It's goiter. Whether it is hyperthyroidism or hypothyroidism, one thing which is called as goiter will be there. Okay, whether it is hypersecretion or hyposecretion, if there will be goiter, the physical effects will be the same. The physical effects of thyroid disease, the physical effects of the thyroid gland will be the same. Because if there is enlarged thyroid, there will be airway difficulty, there may be retrosternal goiter, there may be airway compression, there may be there may be hoarseness, there may be dysphagia, there may be respiratory difficulty, there may be problem you can see in the flow volume loops. There is no difference between both of them. There may be tracheal deviation. So I hope you got my point. So whether it is hyperthyroidism or hypothyroidism, this thing will be the common. Okay, you got it?
Yes, sir.
Okay, so and the other thing will be that in both the types there may be some autoimmune problem. Okay, just like in Hashimoto's thyroiditis or this Graves' disease. So when Graves' disease is there, there will be eye signs which will be or not in all other types of hyperthyroidism. Okay, so this is something a little bit different. There may be some more details. They can ask you about Graves' disease with reference to eye changes. Can anyone explain how this occurs, this eye changes? Sumera or Aiza, who wants to tell?
Sir, in Graves' disease, there is formation of the antibodies, and these antibodies react with the ocular muscles, and
Okay.
leading to lid attraction, lid black, conjunctivitis, exophthalmos.
I think there is some destruction of the I don't remember exactly. But there is some destruction of the connective tissue which is holding the eyeball, if I'm not wrong. That's why the eye bulges. Okay, just reconfirm it, because usually this is not clinically significant. So the things which practically as a consultant we don't need, sometimes we forget. So this is one of them. So reconfirm it, because they might ask you why this exophthalmos occurs. Okay, and
Okay, sir.
there may be some things related to, because sometimes they are doing tarsorrhaphy, just to prevent the eyes, because eyeball is bulging and there are chances of eye injury. So sometimes they are doing it for that procedure as well. This is one thing. And of course, even if you are anesthetizing thyroid patient, so one of the care which you should be doing it is this one. Especially, for example, this is also a practical aspect, that if you happen to have a thyroid disease patient for any spine surgery, in which you have to need to make the patient prone, it will be, you have to be very careful. And actually you have to document about it, because there may be some injury to eye despite all whatever care you do. Okay. So these are some of the things for which you need to document your findings, and you have to be very careful. This message is all for the junior and the residents as well. Okay. So when you are evaluating, there you will be asking some points about the history, examination, and investigations. Okay. So history points, some of them I have already told you will be the common. The other will be, some will be related to hyperthyroidism, which will be, what will be the common features in which you should be focusing in history about hyperthyroidism. What will be the points you will pick? One of you tell about hyperthyroidism, one of you tell about hypothyroidism. Okay.
Sir, in hyperthyroidism, first we will ask about the effects of thyroid hormone on different systems, especially on cardiovascular system. We will ask about the like any arrhythmias like atrial fibrillation,
Listen, Samara,
tachycardia.
if you will answer this question to the examiner will take you, not fail you, but it's a very bad impression. I'm asking about history and you are telling me findings of the patient will tell arrhythmia, or patient will tell cardiovascular
No,
problem.
he will
What
ask about
patient
the
will tell?
tachycardia and
No, even tachycardia is not.
palpitation.
Palpitation. Okay.
Palpitations.
Yes, palpitation is the answer. Okay, palpitation and heat intolerance. Okay, menstrual problems. Yes,
Weight
Aiza, if you
loss.
can correct it, please.
Yes, sir. In history, we will ask from the patient about the weight loss history, about heat intolerance history, about the palpitation history, breathlessness history, increased appetite, and in
Dysphagia.
hyperthyroidism, sir, there is oligomenorrhea, yes, or
Yes.
dysphagia,
Tremor.
and blurred double vision,
Okay. So
and exophthalmos, we can see.
because the examiners, this question is not to see you whether you are able to, this is just for actually for communication skills. I'm this answering, telling this point with reference to Pakistani exam for local long case. So just imagine yourself that you are talking to someone, to a doctor, and the doctor doesn't know difference between history and examination. Okay. So this will not create a good impression. So just try to figure out what are symptoms. Symptoms are history and signs are examination. Okay. So just try to filter out in that way. There are something which are signs as well as symptoms. Some of them is, for example, jaundice. Some of them is, for example, pallor. Okay. This is a thing which the patient can tell you, and it's a sign as well as symptom. But majority, there are something which are called as signs and something which are called as symptoms. So you have to, and this is, remember one thing, this is the failure point in long case. Because the examiner, they are just checking you out whether you have the capability to communicate with the patient or not. Because as anesthetist, this is a very important thing. And when they are asking you about investigation, actually they want to check it out whether this doctor is able to communicate with the surgeon with reference to investigations or not. Because whatever investigation you are doing, you are not doing it for the sake of investigation. You are doing it with sake of any inference or interpretation or next step. Okay. So I hope you understand. So similarly, opposite symptoms will be of hypothyroidism, like cold intolerance and like generalized malaise, low mood and depression. So things like that. Okay. So there is not much, but the main point I have highlighted to you. Now, if you are looking at the examination, so again, as I told you, that the signs of compression will be the same. Signs of, you see, whatever they have written here, retrosternal and all this will be the same. Okay. The only thing difference will be with reference to hyperthyroidism, you will find some tachycardia and some failure of some specific signs like tremors. Okay. So this will be a little bit different. Okay. So what other examination finding if someone asks you what findings you will get in hyperthyroidism or hypothyroidism? So again, Sumera, hyperthyroidism.
Sir, findings during examination.
Yes. Specific, common things are common. Okay. Common will be the compression sign. Common will be.
Sir, airway related to airway examination, there will be a swelling in front
No.
of the
This
neck.
is common thing. I'm talking about specific to hyperthyroidism.
Sir, specific to hypothyroidism, there will be eye signs if it is a Graves' disease.
Very good. Very
and
good.
Then there will be tremors.
Very good.
And examination, we can pick atrial fibrillation.
No, examination. How will you pick atrial fibrillation or examination? You can defend your answer.
Sir, if we if you check the blood pressure and then we check the pulse.
Actually, the pattern of pulse, there will be irregular pulse. Okay.
Yes, sir.
Yes, Aiza, what you want to add?
Sir, exaggerated response reflexes होंगे.
Yes, exaggerated reflexes in hyperthyroidism.
In hyperthyroidism,
and
yes,
depressed.
and delayed reflexes in hypothyroidism.
Yes. Okay. So you see this lid lag, lid retraction, exophthalmos. So these are the signs. Okay. So actually, I'm just trying to touch the main aspects. Oh, okay. So how will you interpret investigations, both in hyperthyroidism and hypothyroidism? Again, what will be the common investigations? The related to airway will be the common. In all, if you want to see the tracheal deviation, what test you should be doing?
So for tracheal deviation, we can go for
Yes,
X-ray test, lateral view, and even we can go for if there is a retrosternal extension, then we will go for CT chest.
Okay, you said chest X-ray lateral view. How will you check the tracheal deviation in X-ray chest lateral view?
Sir, for deviation, it will be AP view.
Okay, so you said something wrong. Okay, so just try to be clear. Yes, Aiza?
Sir, it's AP view if we want to check the deviation.
AP view and,
but if we want
and
to
CT scan.
lateral
CT
view.
scan.
Yes, sir. Lateral view is, sir, for retrosternal extension. If you want to check for retrosternal extension.
Yes, and another in lateral neck X-ray, what will you see?
Sir, retrosternal extension.
Neck. You can see, but more important is something else.
So tracheal compression.
Very good. Tracheal compression. You will see the tracheal compression. Okay. So if you see a tracheal compression, what problem will you anticipate? Because the findings of investigation or symptoms, you should be correlating with the clinical management. Okay. If you see there is tracheal compression, what you should be thinking about?
Tracheomalacia.
Very good. Tracheomalacia. So maybe patient needs postoperative ventilation, or you have to plan accordingly, because this patient can have postoperative airway obstruction. Whether they will go for planned extubation or they will go for tracheostomy. This will be a multidisciplinary team discussion, but if you see tracheal compression, you should be worried about it. Okay. So what will be the rationale for Nase endoscopy? Nase endoscopy is to again to see the tracheal
Sir,
deviation,
to see the preoperative function of the vocal cords.
vocal
And
cords.
sir, vocal cord functions.
Because for example, if you damage this, if one side is already damaged, so the other side, for example, is more prone to create more problems. Okay, so you should be doing this Nase endoscopy. Other test before previously which used to be done for Nase endoscopy was
IDL.
Okay, indirect laryngoscopy. So, and then this flow volume loops again for to see the airway obstruction. Okay, especially if you see if you don't see and you don't have any tracheal compression, or if you don't have retrosternal extension, would you like to do flow volume loops?
No, sir.
No need.
No.
Okay, there is no need in that scenario. So similarly, like whatever test you are doing, and because some tests will be according to the medications. Okay, so for example, if we just think about the medication which the patient of thyroid disease will be taking, what will be the medication which patient will be taking with hyperthyroidism?
Carbimazole.
Okay,
Sir, patient of hypothyroidism will be taking
Propyl thiouracil.
yes, carbimazole, propyl thiouracil. What else?
beta blockers, steroids.
Okay, what else? One medications will be for the release, and one medication will be for the metabolic effects. Okay, so and one medications will be for the peripheral conversion. Stop it. Usually, if you have whether this is you are doing in preoperatively, majority patient they will not be taking steroids. Okay, they will be on carbimazole or propyl thiouracil. Okay, so what will be the investigation you need to do for this propyl thiouracil or carbimazole? What are the side effects?
Sir, it's
Sir, both
thrombocytopenia,
granulocytosis
bone marrow suppression.
Bone marrow suppression.
and bone marrow suppression.
Okay, so rashes, arthralgia, pruritus, agranulocytosis. For again, so and beta blockers, what will be the side effects? What things you should be seeing?
Bradycardia.
Bradycardia, hyperkalemia. Okay, what else? Anything else you can see?
Sir, bronchospasm.
Bronchospasm.
Hyperglycemia.
Not hyperglycemia.
Beta 2 action.
The beta 2 action will not cause hyperglycemia.
Black.
Okay, beta blockers will actually mimic the sign symptoms of hypoglycemia. Okay, because
correct.
whenever there is hypoglycemia, there is tachycardia. So these symptoms will be okay. So otherwise, if patient is taking thyroxine for hypothyroidism, there may be, because if it is not exceeding, there will be no apparent side. Is there any side effect of thyroxine?
Hypothyroidism.
No. Thyroxine. I think no. There will be, because you got my question, Sumera and Aiza?
Yes, sir. Sir, can it cause a hyperthyroidism? Thyroxine can cause hyperthyroidism.
Yeah, that's what I'm saying, that if patient is not overdosing, I don't think so there will be anything specific about thyroxine. Okay.
Right, sir.
Okay. So I think preoperatively things we have almost covered. CT scan, Nase endoscopy. Okay. So anyone wants to add to what we have discussed? Blood test, calcium levels. Okay, calcium levels are important with reference to parathyroid. Okay, and airway, because I'm not going in details of airway examination. We will do it in some separate, but airway examination with reference to the thyroid size. Okay, thyroid dimensions, and then the test which they are doing for obstruction as well, this Pemberton sign. Okay, then mouth opening, distances. Okay, and then neck mobility. Okay, this Malampatti and mandibular protrusion, all the airway examination routine, you are doing it, and then you are adding for with reference to retrosternal compression deviation. Okay, so we will just have a look what else. CT scan, nasal endoscopy, cervical plexus block. Okay, so I think we will stop here, and the remaining portion we will do tomorrow. Okay.
Okay, sir.
Tomorrow, inshallah. I hope, is there any question? I hope you understand. Remember one thing: if you have the concept, you will be able to answer. If you don't have the concept, you will not be able to answer. Okay. So these are the questions which are there: how to rule out retrosternal, or how to see tracheal deviation, because these are the questions which they may be asking to you. Okay. So another thing, when will you proceed? It's a very common question. Which test you should be focusing? TSH or T3, T4 levels? Which is more important?
TSH.
TSH. Why?
Tracheal.
And more so in hypothyroidism, TSH is important, or hyperthyroidism more important? It's more important in hypothyroidism.
Hypothyroidism, sir.
Okay, it's more important in hypothyroidism. So if for example, if patient is either hypothyroid or hyperthyroid, you have to optimize the patient. Both clinically and biochemically, patient should be euthyroid for any elective surgery. Okay, and you will find through ECG, and if you find any signs of failure, you will go for echo. Patient may be hypertensive, you will be treating the hypertension. And if the patient is like there is any other side effects, you will be treating accordingly. If there is anemia, you will treat it. And if there are some serious side effects coming from antithyroid drugs, you will stop and manage accordingly. Okay. So like metabolic and the local effects of thyroid. So you will be doing chest X-ray, ECG, echo, thyroid function test, one more thing, thyroid scan. Okay, this is not too much important for us, but in the exam they ask you these questions as well. Thyroid scan, hot nodules, cold nodules. Okay, and you know what is the problem? Because you people try to total segregate hyperthyroidism, hypothyroidism, and you are not looking at the common things. Because if you know the common things, it will be very easy for you to only distinguish hyperthyroidism and hypothyroidism. Okay. So I just explained to you in slightly different way. I hope you understand. And whenever you have a patient with hyperthyroidism, you are expecting to have this one thyroid crisis. And whenever you have a patient with the hypothyroidism, you are expecting patient going in mixed edema coma, as well as delayed effect of anesthesia, because the metabolism will be slow, and all the medications which are metabolized have more metabolism. There will be chances of exaggerated response. And apparently there is no effect on MAC by either hyperthyroidism or hypothyroidism. Okay, and neuromuscular blocking effects, they may be delayed in hypothyroidism, and maybe need of more more requirement in hyperthyroidism. Okay, so rest of the things, inshallah, we will do tomorrow. So when we'll just, you can have a look on these questions, so it will be easier for you. So whenever like you have a patient for thyroid surgery, you will make it. And then if you have a thyroid patient in emergency surgery, of course, you just have to anticipate and whatever risk stratification you can do. Okay. So thank you very much. Any questions?
Can you tell about Pemberton sign? How to elicit Pemberton sign?
And Dr. Nadeem, in 2022, Pemberton sign, the utility of Pemberton sign is actually not you. It's just a question. It's just a thing which has no significance into 2022 when you have so many investigation. But it is just like they are asking the patient to raise the hands, and if there is some any compression symptoms, what will happen? Then the neck veins will be engorged. So there will be facial flushing and engorgement of the neck veins. So you will say that it is positive Pemberton sign. Yes, and you are asking something, Techno? Hova? Yes.
Sir, is there any significance of indirect laryngoscopy if
No,
there is any
again,
tracheal deviation?
now this test is being replaced by Nase endoscopy.
Oh, thank you.
I'm sorry, there is no use of indirect laryngoscopy in era of Nase endoscopy. Okay, because that is, you refer the patient to ENT and they are just documenting about the vocal cords. So I don't think so anyone doing ideal now. Okay. Okay, so thanks a lot. Inshallah. If I'm not able to do it tomorrow, maybe day after tomorrow. Okay. So tomorrow actually I'm on call. I will try to have a session tomorrow. Otherwise, day after tomorrow. So otherwise, any question you can just drop a message on WhatsApp. And remember one thing, the residents who are listening or who attended, this is how you should be studying. Forget about Viva. Forget about the things which I have touched you. Yes, in MCQs, there will be tiny details which will be asked. In oral part, the questions will be conceptual. But if someone wants to segregate between written, Viva, MCQs, SAQs, this is the biggest reason for failure. And this is the biggest reason you will be embarrassed when you will become a consultant. Believe me, I am on this side of the life, because now if I'm not knowing anything, the person around me or the surgeon or patient suffers. So if you don't want to be embarrassed that in that part of your life, because this time will go, you will pass the exam, but the responsibility you will have after passing the exam is much more than only passing the exam. So please don't get the knowledge only to pass the exam. Take it on the tip of your shoes. Exam you will pass. If you have the knowledge, there is no problem. There may be some delay or some waiting, but exam you will pass. The problem will start after you pass the exam. Okay. So whatever effort I'm trying to do is just to make you people a good doctor. This is not my only aim to make you to pass the exam. Yes, of course, because there will be a counter argument. People say, sir, first of all, let us pass the exam and then we will take the knowledge. And I guarantee you this will never happen. I can bet about it. Okay. So thank you very much for listening. And inshallah, we will continue. Bye-bye.